Greetings, beautiful humans. My name is Nikki Pappas. I'm a physical therapist here at the VA Medical Center and the SCCE for Site Coordinator of Clinical Education. I'm also a geriatric clinical specialist, so old people. And welcome. Today we are going to be talking about acute care physical therapy and being a physical therapy assistant in the hospital setting. So, chances are you're watching this because you are going to be coming to our site for one of your clinical rotations. And I just wanted to give you a couple of ways you can be prepared emotionally and intellectually for this upcoming internship. So, let's get started. Okay, so today we're going to be talking about information about this specific site and what things are like in our hospital, information about this population, just some review about what acute care physical therapy is, a little bit about discharge planning and how you can prepare so you can feel like you show up on your first day ready to roll. Okay? So, information about this site. This is the Salt Lake City VA Medical Center, and we are just pumped to have you a member of our inpatient squad. So, the rotations that we offer, and you have been assigned one of these, is our acute care rotation. That is where you hang out with me and a few more of my colleagues. That's where we live. That is the acute medicine floor is where I am. Then we have our med surge floor where we have total hips, total knees, things like that, and our ICU. We have the medical ICU and the surgical ICU. So the medical ICU is a lot of pulmonary issues and cardiac issues, things like that, while in the surgical ICU, that is usually a cardiac post-op type of a situation, like having a CABG or an LVAD. The next rotation that we offer is our inpatient rehab unit, where we have our post uh, post-stroke patients or amputation patients or other patients where they just have a really high need and their therapeutic prognosis is good. So they give them 3 hours of therapy a day, typically an hour of speech, an hour of OT, and of course, an hour of PT. So that is one of the rotations that we offer that is in the neuro realm typically. Next, we have our amputation or our wound care uh, rotation, which is an inpatient outpatient hybrid program where you work with some of the greatest amputation specialists around, and they teach you how to do wound care and how to work with prosthetics and all kinds of cool stuff with everything having to do with having your foot cut off. Okay. And then finally, we have our PTA program, which is where we have PTA students come in and they will run our STRIDE program. So STRIDE is a program where in the hospital, we have functionally independent people who are strong, healthy, they're just in the hospital for one reason or another. And they would benefit from getting up and walking every single day, even if they don't have any balance or strength impairments. So that's why we have the STRIDE program here. And we have our PTA who is running that program. And typically, when we have interns who are here for the STRIDE program, we also have them treating patients in the inpatient rehab unit as well. So you end up getting kind of the spectrum of our patients who are the weakest and require the most therapy to the patients who are most independent, who just need someone to motivate them and educate them to get them out and moving about. Okay, so our staff here at the inpatient physical therapy department in Salt Lake City, VA, oh my gosh, we have just some of the most brilliant humans who work here. We're fun, we're funny, we're beautiful. But here is just not an entirely exclusive list of all of the things that we specialize in. We have a couple of geriatric clinical specialists, including me and another therapist. We have people who are really good at acute care. Well, all of us are good at acute care, but some of us are a little bit more on the intensive care side. Our amputation folks, our neuro folks, clinical education. There are just so many things that we, as a staff of about 11 people, are just super pumped about. And so we're constantly learning from each other, and we are constantly ready to teach our students about any of these things. Um, so when you're learning about being an acute care physical therapist, it's a little different than our typical outpatient ortho setting. We have to start thinking about things in a different way, specifically thinking about function. My second favorite F word. Oh my gosh. I love it because I have said this for years that function is my favorite F word. And then I saw this meme. By the way, that underneath that it says food. Function is my first, obviously. Anyway, it says food is obviously. Anyway, I think my jokes are hilarious. Okay, so we're gonna have a different paradigm where we're gonna focus a little bit more on function and like when we are talking about our patient goals, but also our PT student and PTA student goals. So it's a little bit less about like how are you going to progress a therapeutic exercise program? How are you going to do manual therapies, things like that. And it's more about how are you going to help people get out of bed effectively and do transfers, gait, stairs, all of those things. So we'll talk a little bit more about that as we go. But the key here is that it's not just getting people out of bed and walking them. It's about making it skilled. So when we're talking about making it skilled, what does that mean? Well, when you are a physical therapist in a hospital setting, you are around a lot of other providers. You are around physicians, you're around nursing staff, social work, occupational therapy, many different types of nursing practitioners. And so, with all of those things, how can we set ourselves apart? So when we're saying make it skilled, we mean that only a physical therapist could do it. Only a physical therapist could write that note. Only a physical therapist could provide this intervention or this assessment. So, for example, from the outside, it looks like we just get a person out of bed and we get them up, we walk them, bring them back to bed, and then we call it for the day. But what makes it skilled is that we are assessing their balance. We're assessing whether or not their vitals stay normal throughout. We're assessing how much physical assistance do they need. Are they independent or are they min assist? So we are really looking at that bed mobility, transfers, gait, and stairs in a way that no one else in the hospital can. A physician can't write the notes that we write, can't do the things that we do. Okay, so that's how we're making it skilled. And I recognize, because I was in PT school once too, that acute care kind of has a reputation and a lot of misconceptions around it. So, acute care physical therapy has a reputation for being kind of the lift team. So if there's a patient on the floor, they're like, lift team, get in here. And then a bunch of physical therapists come and help the patient off the floor. Or this patient is stuck in their chair and PT needs to get them out of it. But it's so much more than that. It's so much more skilled than that. Um, so a lot of people just think that we just walk patients, that we provide mostly bed exercises. Oh, this was something I heard a lot in PT school about the idea um, that acute care physical therapy is boring because all we do is quad sets and ankle pumps. And although quad sets and ankle pumps have a very valuable place in the post-op world after someone's had a knee or a hip or something like that, I personally do not use exercises like that because the best exercise is the one that is the most functional, in my humble opinion. So yeah, people have the conception that it's really easy or it's really boring. And I can't speak to boring. I'm never bored in my job. But I think that when people come in expecting this to be easy, then they miss a lot of the nuances of being a physical therapist in the acute care setting. So having the expectation that this is something that um, can be really physically demanding and also really requires you to know your stuff and be confidently able to take somebody else's safety into your hands. Oh, it's so cool. Acute care physical therapy is awesome. So things that rule about acute care PT. One is that we have the coolest team. That is just hands down. No one can disagree with us. Number two, and I think the most important thing that's cool about being an acute care physical therapist is the schedule flexibility. So if you go in and somebody is in the middle of a procedure or they're out of the room to go to X-ray or they're talking to another provider, they're working with OT, you can just go see your next patient and then swing back and try again. The ability to make your own day and figure out who you're going to see first, who you're going to see last, what you're going to do in case someone's unavailable in order to make your time more efficient. It's so great. While in the outpatient clinic, if someone no shows, you just kind of have to twiddle your thumbs until they arrive. So that's the schedule flexibility is everything. Um, Next is the real life implications of the treatment. So, um, people come in to the hospital with any variety of illness and impairment, and it can impact their ability to move. A UTI can knock somebody out to the point where they suddenly can't get out of bed anymore. And so our ability to assess them and then treat them, it it literally is the difference between going to a nursing home or an ECF and going home with their family. It is, uh, our job is amazing. It's so connected to their everyday life. Next is connection and vulnerability. You're seeing people at their worst when they're in the hospital. And so the ability to connect with people, whether that's one time while they're in the hospital or over the course of weeks while they're in the hospital, there is just nothing like the ability to be there for somebody when they're kind of at a terrible time in their life. And of course, I love the interdisciplinary collaboration. We work so closely with our OT staff, our physicians, the nurses. We have such a great relationship with all of the other providers in the hospital that you just don't get in the same way in an outpatient setting. So it's complex. Um, a lot of times we have a fast pace, constant reassessing. You're constantly monitoring vitals, and you're also recognizing like if there is a mental status change during your session, then fast pace, we got to talk to somebody. We got to make sure the doctor knows. So our role in assessing how people are doing really directly impacts how they're medically being treated. Um, and then we have our constant interaction. We are constantly getting feedback from the patient and providing information to other providers. So whether that's feedback about other people's treatments or just like today, we had a patient who could not tolerate exercise without their blood pressure tanking, which is a bad sign. Your blood pressure should go up when you exercise, and this person's blood pressure was going down. Bad news bears. So those are the kinds of things that we will catch and communicate to the doctors. Next, we have a lot of equipment. So the APTA says that you need to, as an entry-level physical therapist, you need to be able to manage supplemental oxygen, a urinary catheter, and an IV pole. Okay, and so those are the very baseline of what a physical therapist needs to be able to do before they graduate. And we also have other equipment and other lines that we're going to be managing, like the telemonitors, chest tubes, LVADs, wound vacs, so many other things. And so, although you don't have to know those in order to graduate, those are the types of things that we will have a lot of our students getting comfortable managing. You'll get good at recognizing different diagnoses and comorbidities. Like you're working with someone with a heart issue, and is it a plumbing issue? Is it a structural issue? Or is it an electrical issue of your heart? And we'll talk about that later when you're in your clinic. We'll talk about the heart house. It's going to be great. Remind me if I don't talk to you about it. Heart house. It's a thing I made up. Anyway, so you're dealing with a lot of different diagnoses and a lot of different comorbidities. And so you get really good at figuring out how treating one condition is one thing, but then you add diabetes into it, or then you add a COPD into it. It's a lot of things you have to kind of keep straight in your mind, and you have to work in a lot of different layers. Okay. Space and time constraints. So, um, working in a hospital room when there's a lot of equipment, there's a lot of chairs. Some of the rooms are bigger than others. Some of them have roommates, and you have two veterans in one room. Um, that can really require a lot of problem solving. We always call it like the Tetris game, where you go in, you're like, all right, I want this walker to fit right here. I want them to get up on this side of the bed, so I have to move the table over here, which means the chair goes over here, and all of that kind of stuff. So it does make the environment a little tougher to work in. And then, of course, we have our status changes from day to day, minute to minute. And we have to always be ready in case there's an emergency because these people are in the hospital. There's a reason they're here. And so, if they become medically unstable, they have a change in status, or heaven forbid, they code, those are the types of things that we have to at least be prepared for. But we will get you to the point where you are comfortable in those situations because most of the time it just means calling for help. Okay. So, what are our values as physical therapists in this particular department? So, in our office, we value humor. It's a great way that we connect with each other and with the patients. And so, the ability to just be funny with each other and be clever, it's something that we value. We also value the work-life balance, which there are a lot of offices out there that will have their PTs staying hours after their shift. And we are not those people. That doesn't mean that our students won't sometimes stay after because they have to, like your documentation takes longer, things like that. There are certainly going to be times when students will stay after the 4 o'clock time when we're all leaving. But in general, we always facilitate a healthy work-life balance for each other and for ourselves. So that means we set boundaries for ourselves. We expect other people to set boundaries of their needs. So that is a big value of ours. And of course, we expect excellence. We value excellence in our office. We want we are constantly asking each other how we can improve so that we can offer the best possible care. And of course, personal growth. We all value the ability to learn more and be better. Okay. And what we value in our students. One is a willingness to be wrong. You are absolutely not coming to this internship to show us what you already know. Although we're going to quiz you, we're going to check, but that's mostly so we can see what we still need to teach you. But no one has ever gone into an internship as a practical exam where you just come in, you know everything, and then you like demonstrate that you know everything and you leave. You're coming to learn, and we want you to be comfortable with the fact that you're not going to know everything. Okay? So you have to be willing to try and you have to be willing to fail. And that can be really tough for some folks, especially if they have a kind of perfectionist thing going on. So that's something that we really encourage is we try to facilitate a safe environment where you feel comfortable failing. Also, the most successful students are not the ones that were the most intelligent. They're the ones who were best able to self-reflect, the ones who were able to say, I did this really well. In addition to, I could have improved on this. Okay. Self-advocacy. If you're having a stressful time, we want you to be able to talk to us about how we can help you because we're here not only to teach you how to be a physical therapist, but also a human. We love it when you demonstrate curiosity and vulnerability. And of course, when you take initiative for your own learning and for like your patient care, right? Like when you start running the show, that is a good day for us. Okay, quick talk about the population. So basically, we're going to be working with veterans, and most of these folks are geriatric. Um, because a lot of times people think the VA, they think they're going to be young people who were in the most recent conflicts, but really, those folks are still active military, and we are seeing the folks who are no longer in the military. Our largest population is the Vietnam era. But yeah, let's talk about this. So here are the branches of the military. So first we have the U.S. Army. This is where my dad served back in Vietnam. It was founded June 14th of 1775. Fun fact, the Army is the oldest branch of the U.S. military, established before the Declaration of Independence was signed. Oh, go Army. All right. And then there's Navy. This is my grandpa. Um, it was founded in October 13th of 1775. The fun fact is the U.S. Navy has over 300,000 active duty personnel, making it the largest in the world by personnel alone. Next, the Marine Corps, my other grandpa. So in they were found it was founded in November 10th of 1775. Fun fact, the Marine Corps operates as a rapid reaction force and has the distinct motto Semper Fidelis or Semper Fi. So you'll hear that a lot. Semper Fi, always faithful. The United States Air Force, my dad's best friend. I have people in all of the branches, all my favorite people. Um, Founded September 18th of 1947. Fun fact, the Air Force was originally part of the U.S. Army as the Army Air Force beginning before they became a separate branch. So that's fun. Okay, and finally, we have the United States Coast Guard, founded August 4th of 1790. Fun fact, the Coast Guard is both a military and a law enforcement organization with responsibilities ranging from maritime safety to environmental protection. Love that. So, here's some cool things about working for the VA that the service provided are based on need and less on insurance, at least in this setting. So if a patient needs 5 minutes of our time, we can give them 5 minutes. And if they need an hour and a half, we can give them an hour and a half. That level of flexibility that we see at the VA is a lot different than what we see in the private sector. And by the private sector, I mean not the VA. Where you guys go to the hospital is the private sector. Also, the veteran community is absolutely exceptional. The way they communicate with each other, the way they communicate with us. And it's just an honor to serve those who served. And of course, there are so many unique stories and there are so many amazing personalities and a lot that are inspiring, some that are just funny, some that are just wild, and you'll get some stories that you will be telling probably for the rest of your life. So, a couple of special considerations for working at the VA. When you are working with a veteran population, knowing about how to work with folks with PTSD or complex PTSD can really help make sure that that we're providing a trauma-informed level of care. MST, which stands for military sexual trauma. There is a large proportion of our veteran population who has experienced military sexual trauma. Approximately 80% of our women veterans have experienced it, but the sheer number of men who have also experienced it during their service is significant because there are so many men in the military and it is so rampant. So knowing that we have a large portion of our population who has experienced military sexual trauma can also kind of points to that trauma-informed care. We also have a large proportion of unhoused individuals and those who are living with poverty, and of course, diverse political views. And there are certain times where when people are communicating some of their political views, it's just something to be prepared for so that you can set a boundary if it makes you uncomfortable. There are a lot of ways in which we can continue to talk about how these things may impact your time with us. So in general, veterans often respond very well to humor, which I love because that's our value in this office. But they also respond very well to authenticity. They can often tell when someone is trying to be something that they're not, and you will see just we call it the Isle of Misfit Toys around here because there are just so many unique individuals with and just with their own ways of expressing themselves. And veterans always just appreciate when you can just be yourself, exactly who you are. And they also really appreciate active listening and, of course, demonstrating that you care. Okay, so a quick review of acute care PT. You probably learned this in school, but it's also likely that you forgot most of it. So, things that skilled PTs and PTAs will use to get information. They'll do a chart review. They'll look to see if somebody is medically stable or appropriate for PT, using those diagnostic tests or imaging results, looking at the lab values. They'll also find if they have surgical precautions or after they've had a procedure, any activity limitations like weight bearing restrictions, things like that. And of course, their vitals. So, for those of you who are physical therapy students, we will be doing a lot of examinations. In the examination, you are going to have your 6 essential history questions. Other questions are still valid, but we need at least these 6 questions in order to initiate a session and perform a functional assessment. So, house versus apartment versus in a facility. Does anybody live with them? Do they have any stairs in their house? Getting into the house, or like once they're inside, is everything on the same level, or do you have a split level, 2 levels, etc.? Do you use an assisted device like a walker, a cane? How are you doing with your ADLs, like bathing, dressing? How are those things going? And then, of course, physical activity. Do you only move around when you need to do something? Or do you go for walks for funsies? That kind of thing. And then you have your optional questions as well, like have you had any falls? Do you have diabetes and wear special shoes? Or do you have any concerns about your safety going home? So the physical exam, I've said it before and I'll say it again. We're going to go right back to that function. We're going to go bed mobility, transfers, gait, and stairs. And anywhere along the lines, if if at any point they are no longer stable, like they are unsafe, they're not tolerating it, then we will end the session. So not everybody is going to do stairs. So with every patient, you're going to sit them up. Do they sit okay? Great. Then we stand up. Do they stand okay? Great. Then we walk. Do they walk okay? Great. Then we do the stairs. So the skilled part is that moment when we say, do they sit okay? Because that's the part where it's like, are they using their hands to help them, and or are they suddenly sweating and they have they're short of breath now. So when we're doing this, the skilled part is assessing how they're doing and when we should stop and when we should keep going. So those are the things you're going to learn as we go along. And we're going to pay special attention to whether or not they're a fall risk. How is their balance? Are they using a cane, but now they need something more stable? So we think about giving them a walker. How's their safety insight? Did they try to run to the bathroom while they have an IV still like attached to their arm? So those are the things that we'll be paying attention to. Oh, and my very favorite thing is patient education. I think that a PT needs to be really, really happy with the sound of their own voice because they have to talk a lot throughout their careers. So we're going to talk to them about like how you're good at what you practice, and functional mobility is really important. You want to the benefits of getting up, the benefits of getting out of bed, because most of the time they don't want to. They're comfortable. So we have to make it sound amazing that getting up and moving is going to be exactly what they need. So we recommend that you go through and maybe think about some of these things and practice saying them out loud because you're good at what you practice. The patient is, and you are too. So think about that. And so all of that knowledge that we have, all of that levels of assistance and what like all these observations that we're able to make. We're going to apply that knowledge because we are the mobility experts. And so we're going to improve the safety for these patients while we are working with them, but also in between sessions too. Um, and so we have to make sure that we challenge our patients appropriately, which is the hardest part for every single student because they became a therapist or a therapist assistant in order to help people. So having someone struggle to get out of bed, let alone a veteran, it could be really tough. You just want to jump in there and help them. But no, we have to let them struggle because otherwise we're not going to know how much assistance they really need. Are they able to go home? Do they need an assisted device? All those things. So you let your patient struggle. You're going to use your words. You're going to make suggestions on how they could perform the task better. Um, you're going to use your equipment. You're going to move the bed in a certain way. You're going to move the bed up to help them stand, things like that. And then after they've struggled through all that, then you can use your body. Then you can actually physically help someone. But really, our job is to let them struggle as much as possible because that's how they build strength. And then we're going to be analyzing their performance throughout all of this. The quality, the efficiency, are they compensating? How's their motor planning? And so it's not just about their movement and about their ability to do bed mobility, transfers, gait, and stairs. It's about how they're moving and is this going to be safe with them going home? Okay, so discharge planning. We cannot keep them in the hospital forever. So we often, when we're in a hospital, we have a team dynamic. We have our doctors, social workers, all of these other folks who are planning for the patient to leave the hospital when it's time. The doctors decide when the patient is leaving, when they are medically stable to leave the hospital. And our job in the therapy team, PTs and OTs, our job is to make recommendations on where they should go. So we don't decide when, we decide where. So our options are home with no PT, home with outpatient PT, home with home health PT, going to an extended care facility, which is an umbrella term for a SNF or a nursing facility, things like that, or are intensive inpatient rehab units. So the places where you'll get 3 hours of therapy a day. Okay. So our job, we are at the forefront of deciding if the insurance company should pay for a patient to go to an extended care facility. And so when we are making this plan, we are going to perform that functional assessment, how they bed mobility transfers, gait, and stairs. And so then we're going to look at their level of assistance, like anywhere from independent, modified independent, standby assist, contact guard assist, min assist, mod assist, mass assist, independent. Um, where on that spectrum are they for these tasks? Based on what we see, where are we going to recommend? Not based on their story, not based on other things. What did we see and what recommendation are we going to make from there? Um, Next, we're going to see could they go home if we have a walker on board? We see if there's any equipment that we can provide to help them go home safer. And of course, their potential for recovery. The first day after a total knee, no total knee replacement, somebody might require min to mod assist getting out of bed, but then the next day they're going to be totally fine once their pain is better controlled. And so the ability to recognize, like, you're probably going to get better pretty soon, also will take some time and some practice. So we don't expect you to come in with that kind of understanding right away. Okay, but one thing that we do not make recommendations on is if somebody lives with them. So you don't say, I'm going to send them home if somebody lives with them, because then a we might have a like tiny little wife who needs to help them get out of bed. And not to say that that's not part of it. It's just that's not what you make your recommendations on alone. You don't make a recommendation based on whether or not somebody wants to go to an ECF. If somebody's moving really well, but they're like, I want to go to a facility, we can't recommend a facility if we don't see a reason for a physical therapist recommendation. Same with if their impairments are just cognitive. Some people are wandering around and they have dementia and they shouldn't go home, but we can't recommend a facility because they don't have any impairments with bed mobility transfers, gait, and stairs. Also, if they're medically complicated, like if their blood pressure is tanking or their oxygen isn't good, that's still not a reason for somebody to go to a facility for physical therapy. Okay, so we're going to finish this off with how do you prepare? What suggestions do we have for you so that you can be your most successful and hit the ground running when you get here? So, things that you should know backward and forward. One, levels of assistance. I know that the independent, min assist, mod assist, all of those things, they seem really basic when you're in PT school and you're like, oh yeah, I memorized it. But you need to know it backward and forward. And don't forget that standby assist and contact guard assist exist, because a lot of folks just go right from independent to min assist. Don't forget those middle ones. They are so valuable. So know all of those very, very well. Next, know your weight bearing restrictions. Know the difference between non-weight bearing, any of the partial weight bearing spectrum, and the weight bearing is tolerated, and what assisted devices are appropriate for each of them. Next is you should know all of the assisted devices from most stable to most mobile. So stable being like the parallel bars. They're super stable, but they're not mobile at all. They're not functional. And then you have your most mobile, which is maybe your single point cane. It's really mobile, but it's not very stable. You can't be non-weight bearing with a single point cane. So really brush up on those things. Look into your vitals and their norms. And surgical precautions. You should know like the spinal precautions, abdominal precautions. Some of the hip precautions are getting a little outdated, but still know them in case they come around. And then, of course, move in the tube. Get to know that one as well. For your coursework, review your pathophysiology. Look into those heart diagnoses and the heart and lung anatomy, lung and kidney diagnoses. Know about diabetes, Alzheimer's, and dementia. And then, of course, it could be helpful to know about mental illnesses like PTSD, schizoid type disorders like schizophrenia or schizoaffective disorders, anxiety, and depression. That could be helpful. And I just really want you to recognize our expectations of you. We expect you to show up preferably on time. We want you to engage with your CI. We want you to respect the setting. We know a lot of people come in and they're just super pumped on their outpatient ortho stuff, and they're just not really super looking forward to acute care. But respect the setting because you're going to love it if you just buy in. Um, by the way, most people do. They love it here. We expect you to ask questions, and and we expect you to make mistakes. Not our expectations. We do not expect that you will remember everything that you learned in school. We do not expect that you will remember everything we say. And we certainly do not expect you to perfectly replicate our performance. Most of us have been doing this for more than 10 years. And so the idea that you would come in fresh out of PT school, never practicing in an acute care setting, and just immediately thriving, that's an unrealistic expectation. So do not project that on us. So, in conclusion, functional mobility is where we center our evaluations and our evals. So we could do like it's not that we never do balance training or other outcome measures, but a functional assessment is key to everything that we do. Okay. Um, we expect you to come in knowing nothing about hospitals. And if you do come in knowing something about hospitals, great. But we always expect that everybody comes in knowing nothing about the machines and the beeping and all that stuff. You are coming here to learn. You are not coming here as one long practical exam where you prove what you already know. Okay. So practice safety, while allowing yourself to make mistakes. So we have an awesome team. Please let us help you learn. Use us and be an engaged team member and take initiative for your learning. So keep on using your words and ask all of the questions. Okay. So we will see you soon. And don't forget that the student handbook that we sent in your initial email, it has the schedule, the dress code. There is so much important information in there that you don't have to memorize, but it will answer a lot of your questions. But you can call me, you can text me, and we are absolutely pumped to have you as a member of this team. So thank you so much. And yeah, we'll see you soon. Bye.